Hi everyone, I'm Vanessa Broadbear, and depending on the time of day or the current time zone that you're in, good morning, good evening, and thank you very much for joining me to talk about my applied practice experience, which we will refer to as APE here in this presentation, that was completed for my master's in public health program at Eastern Washington University in the fall of 2025. As you can see here from the design on our initial slide, this APE had a focus on mother and baby health. So while the two projects were different, which we'll talk about here in just a couple of minutes, the focus was definitely on mother and baby health. So let's get started. All right, so just a quick overview. I'm going to be talking about giving you some introduction and background, and then we'll talk about our two projects, which was Safe Sleep and TeamBirth, as well as the competencies those projects helped cover. And then we'll have conclusions and reflections at the end. All right, so for my introduction, my APE took place at Brigham and Women's Hospital, which is located in Boston, Massachusetts. And that took place around 12 weeks through September to December during my fall two session at EWU. I worked at Brigham and Brigham and Women's Health as a health administrative intern under Labor and Delivery Department, and I actually did my APE during my off hours at this internship. So this is where most of my work for my APE, my two projects, happened. The first project was Infant Safe Sleep Campaign, which was in collaboration with Brigham's NICU and community health centers under the Mass General Hospital system. And Mass General Hospital is a really big hospital conglomerate here in Boston. It's kind of like a medical mecca, if you will, and Brigham and Women's Health Hospital falls under that. So again, did most of it at Brigham, as well as the health centers that fell under Mass General Hospital, Brigham. All right, so for my second project, which was a post-implementation evaluation of TeamBirth, which just for short, TeamBirth is a popular new care model being rolled out across the country, emphasizing patient's choice and shared decision making in the labor and delivery process. So we'll get into more detail about that in the following slides. All right, now for some background. While most of the work, like I said, for my APE took place at the NICU, labor and delivery, and the antepartum departments at Brigham, most of our outreach also took place for Safe Sleep occurred at some of the Boston's local community health centers. That included Brookside Community Health Center and Southern Jamaica Plains Community Health Center. As for my site supervisor, Melissa, she was fantastic. She is fantastic. She is a registered nurse. She works clinically as a labor delivery nurse and then administratively as a professional development manager of obstetrics. So ultimately, I would like to refer to her as my mentor for the rest of this presentation because she was extremely invested in my experience and was integral in helping me develop what my projects became. Initially, we had a few meetings to discuss my ideas on potential projects, but she helped me navigate kind of like the realistic expectations and logistics of each of those. So ultimately, her knowledge and expertise kind of helped dwindle down the final projects of what Safe Sleep and TeamBirth became. Her clinical experiences were also valuable insight into staff perspective, and her administrative positioning helped me get a seat at the table for several department meetings that ultimately gave me access to important stakeholders in the community. All right, finally, for the background, moving into my student roles during the APE, my role within the Safe Sleep Project included campaign development, being a permanent fixture or representative for the program in the community. And in my opinion, the most important role was being a community educator. Within the TeamBirth post-implementation project, my main role was essentially being like a third-party evaluator of the program, of the TeamBirth program, and then also being a re-education leader. I specifically was not an educator of TeamBirth, but was able to identify some of the areas in which needed to get highlighted for re-education, which was then executed by the medical and nurse directors. So in both roles, as I said, I collaborated closely with nurses, physicians, midwives, clinical directors, community health workers, and just a bunch of interdisciplinary partners and stakeholders. All right, moving into my first major work, this was the Safe Sleep campaign. I want to get into a little bit more detail about this on this slide. This project was inspired by one of the emphasis items of Brigham's NICU. So at the NICU, obviously, we have really premature and small babies that are patients there at the NICU. And the NICU staff and leadership were hoping to prevent sudden or unexpected infant death syndrome, also known as SIDS, through safe sleep practice. So it was in their discharge process to educate parents about the safe sleep practices before those patients could be discharged. So they had this practice already in the NICU, but they also had an interest in developing like a campaign to be able to bring this education to the community at large. So a team of nurses and myself as the administrative intern, we developed a plan to stand up like an educational table at some of like the communal spaces within the hospital at Brigham. So we had this table, and then we also had a demonstration on how to execute safe sleep for the infants at this table. So as you can see in the picture, that's me. And this is at one of those setups at the communal spaces. So as a team, we composed educational handouts, magnets, and a website that the community members could access to gain further information outside of what we had at the table. The highlight of the tabletop resources for me was our interactive safe sleep exercise. So you can see me doing that here in this picture. I'm basically demonstrating the do's and don'ts of preparing an infant's environment for sleep. So what we did is we loaded up the crib, which is this plastic tub here, with our baby, with a bunch of layers, a bunch of blankets, stuffed animals, socks, etc. Just a bunch of junk, essentially, in the crib. And then all the things that are not recommended for the safe sleep, we would work with the member to remove those items. So we would educate them with the resources that we had there at the table, and then it was kind of like a test, if you will, for them to identify the things that needed to be removed from the crib in order for it to be safe sleep. We taught them that ultimately a baby should be alone on their back and in a crib, which this became a mnemonic slogan that we put on the magnets to help them, to help parents, family members, and caregivers remember the basics of infant safe sleep. So alone, A, on their back, B, and in a crib, C. So we referred to this as the ABCs of safe sleep. And so you'll see that in the following slides so you can get a little bit closer up view of some of the products that were there on our table. This photo came from a social media post by a postpartum mothers organization, and they requested to take a picture so that way they'd be able to share it within their Facebook and Instagram posts for the organization. They really wanted to highlight the work that we were putting into the education for safe sleep, which worked out for me because I had a picture to be able to share with you guys. And also I just wanted to demonstrate how something like this, which was done in an academic and kind of clinical environment, made its way into the social media scape. All right, so moving on, the team wanted to take the exhibit that we were doing here in the hospital at Brigham to our community health centers, but unfortunately, none of the nurses had the availability to do so because they were, they were doing great work at the hospital and full-time, so the only person that had the ability to be able to take this on the road was myself. So I took on the solo challenge and I brought this table on the road. I brought the table into some more diverse communities, which exposed some areas of improvement for sure in the campaign. That was into our Brookside Community Health Center and our Southern Jamaica Plains Health Center. And I found that going into these community centers, which I did not realize at the time, or at least planning for it, I didn't realize were so Spanish heavy, with a lot of Puerto Rican community, a lot of Dominican community, and a lot of Caribbean community as well. So while our language translated, specifically our Spanish translated work products, were able to effectively communicate the information to this Spanish dense community. Some of the translations, specifically the mnemonic slogan that I was talking about, the ABCs of safe sleep, didn't quite translate into Spanish seamlessly. So that was one thing that we knew that in the future we would have to change. Additionally, I have to admit that I thought my Spanish speaking level was good enough, or I thought that it would be good enough for me to be able to work alone on this project. I took Spanish in high school, and I took it in college, and I do Duolingo, every single night. So I had confidence that I'd be able to do this on my own, but I quickly learned that my Spanish was good enough to communicate with the community, to communicate the information to the community members, but I wasn't able to really connect culturally with the members, which I discovered is essential in getting buy-in from the patients. So when patients would walk in, because I would initially introduce myself or reach out to them in English, a lot of people would, walk by or be very hesitant to come visit us at the table. So for that reason, I had to recruit native Spanish speaker volunteers from the staff at the community health centers. I was extremely grateful for the medical assistants, the community health workers, and the nurses who basically took their time on their breaks and their downtime to sit with me at the table as not only as a community representative, but as a medical staff representative as well. And it was at that point that I realized that once we had those community representatives, those Spanish speaking representatives, that we got way more influx of people coming to visit the table and like wanting to engage as well, not just necessarily like listen to the information, but had questions, wanted to point out some like cultural differences that maybe like, for instance, of course, it makes like in their culture, a baby would sleep with the hat on because that's how they were raised and that's what their grandparents told them to do. But then we would have to like, get a little buy-in with them and be like, yeah, things change, things evolve. And so this is the new information that we know. So maybe you can pass that on to your parents. You can pass that on to your grandparents. Overall, as we're wrapping up this Safe Sleep campaign, um, I absolutely loved this project. I was enamored with the commitment that the staff members, especially, most especially at the community health centers, had in wanting to improve and educate the community members in like a culturally respectful and inclusive way. So these were the products that I was talking about. Maybe you saw in the picture from the last slide. Over here on the left, we've got the ABCs of safe sleep. A baby should always sleep alone, on their back, and in a crib. Below that, you can see that the Spanish translated magnet, it says El ABC de un sueño seguro. So that translates if you read the El ABC, the translator basically just took ABCs and translated that into ABC. And as you can see, the A, B, and the C don't actually correlate with the intention that we had for the letter to represent the action of each of those like tenets of safe sleep. So I talked with the safe sleep committee that we had at Brigham with the nurses. And so for next year or moving forward with this, we discussed that we probably would have to reassess that and change that in order for it to be culturally inclusive and actually make sense. All right, and then if you move to the center of the page, we've got the ABCs of safe sleep, and with each column, it's a different language. So this was kind of a flyer that also had a QR code on it to be able to visit the website in a language for you. And then finally, at the very top here, we've got another rendition of our table. As you can see, this is what I was explaining with the do's and don'ts. We loaded that baby up with a bunch of different layers, all things that we don't recommend for safe sleep, and the community members were able to peel away the different layers, and we were able to explain to them why we didn't need all of those things. If you're looking at that table, you can see to the right we have all of our products that we put together. And then I kind of want to just highlight really quick over to the left. We have some books that were both in English. They were children's books for English and Spanish translations. We also have some infant beanies, and we had some booties, and we also had some infant clothing that was donated from a bunch of different places in the community. And I didn't speak much about this, but I did think that it was important to highlight that these donated items were really great incentives to gain the attention of the people that were coming in to visit at the community health centers. So again, maybe they weren't intrigued by my English, and then maybe they weren't even really intrigued by the Spanish speaker that was with me to come over and visit. But once we started saying, "Hey, would you like a book?" or "Hey, would you like a beanie for your baby?" That's what kind of drew people in, and we were able to talk more about the Safe Sleep and talk about the campaign. All right, now for our major work number 2. This is the second project that I worked on for my APE, and this was a post-implementation evaluation of TeamBirth. TeamBirth is a team-based care model designed to improve communication, shared decision-making, and patient-centered care during labor and delivery. It brings together the patient, their support person, and the full clinical care team through structured huddles, clarifying roles, aligning care plans for the patient and the baby, and ensuring that the patient preferences and concerns are actively included in decision-making throughout labor. So I just want to take a pause real quick and talk about this. So essentially, the reason why this care model was developed, TeamBirth, this care model, was developed to break down some of the barriers that I think that like patients and clinical staff sometimes have in the labor and delivery unit. Um, Personally, I've not delivered a baby, so I can't speak from experience, but there is definitely sometimes a negative stigma associated with obstetricians and maybe even some like nursing and whatnot when it comes to labor and delivery, that when they have a plan or when a scenario arises that they need to make game time decisions, that they will make those decisions. They will inform the patient of the decisions, and then will take action on those decisions. This has led to a lot of concern amongst the labor and delivery obstetric midwifery communities of patients not having enough autonomy or decision making in their labor and delivery process. So TeamBirth was developed and is now kind of rolling out across the United States because it's become very popular, because it takes into consideration the patient's preferences and concerns, as well as their support person, or whoever their support personnel is, whether that's a birthing coach, a doula, or just the people, their family members that they brought with them. And so with the advocacy for the patient in TeamBirth, they're able to help make decisions about the critical care that they're going to receive in the labor and delivery process. So again, TeamBirth is important because it promotes transparency, it reduces miscommunication, and it empowers patients to participate in their care at critical moments. By standardizing communication and setting clear expectations, TeamBirth helps improve a patient's experience. Obviously, it supports safer clinical care, and then it also, which is most important to us in the TeamBirth sense, advances equity by ensuring that all the patients, regardless of their background, have a voice and a shared understanding of their care plan. All right, so the labor and delivery unit of Brigham Women's Hospital, implemented this care model a few years ago. And during my time as an intern, I spent a lot of time observing labor and delivery every single day, whether it was in a clinical manner or whether it was in an administrative manner. And the reason why I was inspired for this project to evaluate TeamBirth after the implementation was because When I was observing the day-to-day operations of labor and delivery, I experienced and kind of noticed this disparity in how clinical staff members were executing the core team birth tenets and key behaviors. So for this reason, I wanted to evaluate how team birth was used in the department, the challenges and successes of the care model, specifically within the department, and then whether or not the model was effective. And when I say that, like, I experienced some disparities between the clinical staff, it was mostly like nurses are absolute champions of this program of teen birth, of this care model. And that's because nurses are their bedside. They're with you 24/7, right? When they're on their shift, they're with you throughout the entire time that you're there. So they're obviously inherently going to become advocates for the patient. I did notice that, like, there was a bit of not contradiction, but there wasn't as much emphasis on upholding those teen birth key behaviors by physicians, for instance, because at least specifically within Brigham's labor and delivery units, physicians would have several patients that they would have to rotate and visit all the time. So their schedules and just the workload that they had was not advantageous for them to uphold some of these key behaviors. So I wanted to see like I said, I wanted to see what some of those challenges were, and I have already kind of addressed some of them, but then how maybe we could move past those, or what needed to be done in order to overcome some of those obstacles. So for the development and implementation of this project, I used, as I mentioned, those 4 key behaviors, which are outlined in Team Birth's implementation instruction. And I created a survey that asked questions that would help give us an idea on how well the department is maintaining these 4 required behaviors for the program. And we'll move on in the presentation to address some of these. All right, so as you can see on the left, this is a flyer that I created. It contains a QR code with a link to the survey that I developed. And I posted these physically in person on the labor and delivery and the antepartum floors, and virtually in the weekly newsletters and in email distros for all the clinical staff, hoping that they would participate. For now, we'll just focus on this to the left, and we'll come back to the picture on the right. All right, so I'll be going through the survey results regarding the 4 key behaviors to ultimately frame how teen birth was being viewed by the clinical staff. So for these slides, as you'll see, obviously we're going through the results, and then below that is the definition pulled directly from the implementation instruction that came from Teen Birth. I'll read through that, expand on it, and then we'll go to the survey results at the bottom that is displayed in this bar graph and kind of talk about what that means in relation to the key behavior that we're discussing. Something that I'd like to address as well, you'll see the same exact format for every single key behavior. And level 1 there, as you see at the bottom, is disagree strongly. 3 is your neutral, and 5 is agree strongly. So for this first slide, every role team member is always identified, ensuring everyone has an invitation and ongoing opportunity to participate. So for Teen Birth, it's very important that every single person that's going to be in the room with you during labor and delivery, as a patient, who that person is. So that way you have some sort of relationship with that person. So that way it's not weird or you feel disconnected or uncomfortable in some way when it comes down to making those game time decisions in high stakes scenarios. So based on these results, the average rating is 4.38. The clinical staff members who were the participants in this survey, the clinical staff members I would say that they agreed that every role team member is always identified, ensuring everyone has an invitation and ongoing opportunity to participate. So we can say that based off of that rating, the clinical staff basically thought that this behavior was being upheld for teen birth, which is good. Great. That's what we want. All right. For our second key behavior, patient preferences, thoughts, and concerns are elicited, facilitating customized clinical care in every teen birth case. So we have our average rating at 4.25. So again, the clinical staff mostly agree that the patient was heard. They mostly agree that the patient's concerns, opinions were heard, that it was noted, it was displayed on the team birth board that's on every single room, that has all of the information about the patient and the next steps for the patient's labor and delivery. They felt, as clinical staff, that the patient's preferences, thoughts, and concerns were being heard and customized in a way for their labor and delivery care plan. Again, great. That's what we want to see. For our third key behavior, care plans of the patient, baby, and labor progress are differentiated, ensuring transparency and precision during care planning. So something I want to expand on a little bit here is maybe another stereotype that happens in labor and delivery, at least from what I saw as an intern, is that a lot of times it can happen where a mom and baby are synonymous, that it's talked about, that they are talked about synonymously. So teen birth really wants to emphasize differentiating the patient, the mother, the baby, and the labor progress as an action itself, and not all of that is tied together. So they want to ensure that what care is being done for the mother it is because of the baby, but they want to identify that everything is separate and that everybody is getting the specific and tailored care together cumulatively, but not that it's all one same care plan. All right, so the result of this average rating was 3.94. This is very neutral. It's showing me that maybe this is an area that needs to be improved, but of note, there is no level 1 or level 2 that was selected for this survey. So what I interpret in this data is that because it is very neutral, and we'll talk about some other feedback, some actual qualitative feedback that I got regarding this key behavior, that maybe we need to put a little bit more effort in delineating between patient, baby, and labor progress. All right, finally, for our fourth key behavior, expectations for the timing of the next huddle are always set, reducing the uncertainty for the patient and support person. Okay, so I want to expand on this again. Something that I failed to mention when setting up kind of like the framework for teen birth is huddles are key. They're essential for this care model. Huddles are when the clinical staff and any support personnel and the patients come together to talk about the way forward and the care plans that they have for the labor and delivery. This is like the lifeblood essentially of teen birth, and it has to happen, which is why it is one of the 4 key behaviors of teen birth. So again, wanting to emphasize why it's important that we look at this average rating and we see that it's a 3.56. So again, probably another area of improvement. And as you can see, there is some disagreement in upholding this behavior in the bar graph that we have displayed. So again, an area of improvement to ensure that we are setting times for the huddles and that huddles are even just happening in general. All right, so we're talking about our conclusion now for our survey results. So after going through those 4 key behaviors and the survey results, there were some key items, some key takeaways from the survey. Those being improved communication. So ultimately, staff members found that there was improved transparency and open communication, and that is amongst themselves, and as well as amongst the staff and the patient, which is great. That's one of the things that we were hoping to achieve after implementing TeamBirth. Second one, more education requested. So I should note that in the survey, there was multiple questions. I only showed you how those 4 key behaviors were addressed, but there was also an option at the very end of the feedback or the end of the survey to provide feedback, specific feedback in like a qualitative way of being able to give like their input of things that you think is, I think the way that I had phrased it was, is there anything that you would like to address, or any obstacles, challenges that you face that you think that needs to be addressed with leadership and the staff in general? And so some of these conclusions that I'm coming to have some input from those qualitative feedback questions that I got from the surveys as well. So one of those, this conclusion that I'm coming to for the more education requested, did come up repeatedly in the survey, saying that staff members felt like there needed to be more formal training, and re-education probably needed to be repeated and was requested over and over again. All right, moving on to scheduling obstacles. So this was probably when I discussed the disparities earlier, between physician, obstetrician, and the nursing. This was probably the biggest obstacle in the TeamBirth practice. So because of the OB's varying and crowded schedules when they were on the unit, it was hard for them to set a designated time to huddle and to debrief. So a lot of times huddles were not met. Of course, that there are like Brigham and Women's Health labor and delivery required huddles that happen, usually before active labor happens, before they go into the OR. There are times that their hospital policies require them to huddle, but maybe they did not huddle in a way that TeamBirth would have recommended. So they did those policy enforced huddles, but they didn't necessarily do TeamBirth huddles that would have occurred like in the interim between those policy required huddles. So nurses usually sit all together in like a nurse's station. Physicians are doing their rounds and they're moving around. So it's really easy for nurses to stay communicated together and to effectively huddle when they don't even realize that they're huddling. So they felt like huddling was happening in that clinical staff position, but maybe not happening amongst everyone with all of the clinical staff positions and the patient themselves. So because of the schedule, how the OBs were scheduled, it was hard to implement those required huddles in TeamBirth. All right, and then finally, redundancies. So some inefficiencies were identified that include like redundant charting required specifically for TeamBirth events when TeamBirth was implemented. In the system-specific charting that the nurses use, they felt like there was a lot of redundancy, so they had to do extra work to report a lot of the TeamBirth requirements, even though they already had to have reported it somewhere else in their charting for the patient's folder, the patient's charts. So they felt like there's some redundancies and maybe even a little bit of resistance to do those TeamBirth charting requirements because they had already done it somewhere else in the chart. All right, so we're back to our products of TeamBirth slide here. I wanted to point out the right-hand side. Now we're on to our CEPH competencies. So as you can see here, I've created a chart just to identify what competencies were fulfilled and covered by these two projects. As you can see in the columns off to the right-hand side, I've indicated which competencies have been fulfilled by which projects, and a majority of the competencies of the 6 competencies have overlap in both of the projects. It's only competency 4 and competency 19, for instance, that's only fulfilled by one. So as we roll through the slides of each competency and how they were fulfilled by the project, some of them will have overlap and some of them will just be solely from that single project. Competency 4, interpret results of data analysis for public health research, policy, or practice. So obviously this competency was fulfilled by our TeamBirth project. First, that was fulfilled by the data analysis pre-evaluation. So as I had said, TeamBirth had been implemented and executed 3 years prior to me coming to Brigham's labor and delivery unit as an intern. So luckily, Brigham and MGH keep a large database of patient experience, of practices and whatnot, performances. And so I was able to get a huge data dump of everything regarding TeamBirth in those 3 years after implementation. And I was able to tailor and navigate what questions I wanted to ask on the post-implementation evaluation survey. And so by now analyzing that pre-evaluation data, I was able to optimize, I think, the survey to be able to get the correct information or the best information to figure out how TeamBirth could be improved. Secondly, a data analysis that came directly from our survey results as well. So I know that we talked about our survey results already, but being able to synthesize all that qualitative feedback was helpful in trying to figure out what our actionable items were going to be. So from the data analysis from the survey results, we were able to update some of the policy and practices that we felt were most essential for TeamBirth. All right, moving on to competency 13. Propose strategies to identify stakeholders and build coalitions and partnerships for influencing public health outcomes. I think that this was probably pretty obvious, at least in my opinion, in the first project, Safe Sleep. We engaged with community health center leadership. So I met with the NICU assistant nurse director who put me onto this project, Safe Sleep, with the committee of nurses who wanted to do that within Brigham and Women's Hospital. And so we were able to do that within the hospital itself, but collaborating with the assistant nurse director, she had told me that also there were community health centers out there that also wanted to be exposed to the Safe Sleep campaign. And she put me in touch with some of those representatives, and I was able to engage with the community health center leadership and be able to bring this campaign on the road. For TeamBirth, I collaborated with clinical directors and midwives. So I think with Safe Sleep, it was very obvious that I had been interacting with the community to get this program off the ground. And then with TeamBirth, it was mostly interdepartmentally that I was building and identifying who these stakeholders were. So worked with clinical and nurse directors to be able to figure out how we can influence the improvements within TeamBirth, and then also with the midwives as well. All right, competency 18, select communication strategies for different audiences and sectors. Again, I felt like this was very obvious in Safe Sleep, in our Safe Sleep campaign, because we had to adjust so much of our resources and our education products to Spanish speaking communities. So we not only did we just adjust the actual work products themselves, like the handouts and the magnets and the flyers, but we also adjusted our communication strategies for being able to get more buy-in from the patients and from the community members themselves by having that native Spanish speaker there. By having that native Spanish speaker there, we were able to engage more people to come and talk to us and to be able to educate them on safe sleep. For TeamBirth, we presented data and feedback according to clinical position. So while safe sleep was happening in a larger scale community perspective, TeamBirth, again, happening interdepartmentally, um, internally in the department. And while we got feedback and surveyed all clinical staff positions, we did tailor our how we wanted to convey our findings to each specific clinical staff position. So I talked about those small group sessions. Those small group sessions were there for feedback, but we're also there for re-education and whatnot. And we delivered that information specifically based on what the clinical position what we were delivering it to. Competency 19, communicate audience appropriate public health content, both in writing and through oral presentation to a non-academic, non-peer audience with attention to factors such as literacy and health literacy. All right, so we've got our first project, Safe Sleep. We had Safe Sleep educational table and handouts. So again, find this one to be pretty straightforward. All of the products, all of the work products that I've discussed and that we've presented were done to be able to deliver to like the lowest common denominator for somebody who um, maybe has never been pregnant, has never been exposed to babies uh, prior to this table or prior to them becoming pregnant with their first child. So we were able to have this mnemonic slogan, something that's easy to remember, give them a website that is translatable to whatever language is specific to them. So I do think that Safe Sleep was a great example of this competency. And for TeamBirth, so we tailored our small groups sessions for program improvements. While while some of the group sessions were academic in a sense for re-education, again, the small group sessions were also used for program improvement and for open discussion like feedback sessions. So this was supposed to limit the barriers that people might find when in like being in a hierarchy or weird power dynamics. So being able to tailor these small group sessions for each clinical staff position, I think really improved like the public health context that the public health content that we are trying to deliver via TeamBirth in a way that was more appetizing and maybe digestible for that specific staff, clinical staff position. Competency 20, describe the importance of cultural humility in communicating public health content. Again, I feel very obvious in Safe Sleep. Can you tell that I really like Safe Sleep? All right, so for Safe Sleep, adapted products to reflect community language and cultural beliefs and opinions. Um, Again, we see it with our products. We had Spanish oriented, Spanish translated products. But I want to point out that something that was really important to us in having that native Spanish speaker with us is being able to make people feel more comfortable with approaching and coming to learn. I do think that there is a little bit of a social barrier with somebody that you're not able to comfortably communicate with and make that connection culturally with. At least that's what I experienced, I think, at the Safe Sleep tables at the community health centers, is that you found people repeatedly saying something like, well, this is new information. This is not how my grandmother taught me. This is not how my mother taught me. This is not how I was raised, or this is not even how I did sleep with my first one, two, three children. Why should I change now? And I refrain from using the phrase coming from a harm reduction perspective, because in safe sleep is safe sleep, we should maintain safe sleep in order to avoid SIDS, period, dot. But I do think it's important um, that we advocate for the community member, for the patient, and say like, hey, what you did wasn't wrong, but this is what the evidence, this is what the data is showing now. And that's great that that's how you culturally, how you conducted sleep, but maybe this is how we can move forward. And this is information now that you can bring to your children too, and let, or to your grandchildren, or even to your grandchildren in the future. For TeamBirth, emphasizing patient preferences and concerns, respecting personal preferences and opinions. Yeah, so something that I didn't necessarily expand on when talking about TeamBirth at the beginning, and trying to give you a little synopsis of what this care model is the one of the primary reasons that they came up with the TeamBirth care model was to minimize the disparities that are felt among women of color, of women of different socioeconomic backgrounds. Um, Being able to give your patient a voice, and to have a voice in the decision making that's happening at those critical care moments, um, absolutely is providing them and highlighting the importance of cultural humility. So TeamBirth in itself, I think, just fulfills this competency, and it's one of the reasons why I was inspired and passionate about ensuring that TeamBirth is going as well as it can be in the labor and delivery department at Brigham. Competency 21, almost there, last competency. All right. Integrate perspectives from other sectors and or professions to promote and advance population health. Safe Sleep. We engaged with a plethora of different departments, stakeholders, and positions. As I had explained earlier, the whole Safe Sleep moving into the community health center scape was all started with me interacting with the NICU administrative leadership, and then they put me in contact with leadership from the community health centers. When I was at the community health centers, and realized that I needed a native Spanish speaker, then the medical assistants, the community health workers, the WIC representatives were coming out of the woodworks to just be able to help. And so we got a load of perspectives from other sectors and promotions to help us in advancing this public health topic that we wanted to talk about. For TeamBirth, we integrated input from national, regional, and department levels. So starting at the lowest level, department level, I collaborated with physicians, the OBs, the nurses, the midwives, the administrative leadership, in order to help promote a better execution of TeamBirth. At the regional levels, I reached out to other MGH and Brigham associated labor and delivery units, and to see how they were executing and how they were implementing TeamBirth, and what struggles that they faced or what challenges that they had and how they overcame those. At the national level, I was able to work with, you can see here in this picture, um, with the company that developed TeamBirth, and I was able to form a relationship with the subject matter expert for implementation of TeamBirth. She was like the she is a nurse, a labor and delivery nurse, who her whole job with TeamBirth is just to go to the hospitals that are interested in executing and implementing TeamBirth within their hospital, and she stays with them for a couple of weeks and she helps them roll out TeamBirth. And I reached out to her early in the project because I wanted to see how other hospitals were overcoming identifying how hospitals were identifying some challenges, and how they were overcoming some of those obstacles. And initially, my thought going into this was like, okay, I'll get some new product, or I'll get some educational material from her on how people overcame this. And she was like, that's not how it works. Um, every hospital is different, and we haven't come up with courseware that basically says, hey, this is how you overcome some of these obstacles. She said you have to go in and you have to work with every single department, every single hospital, to identify those specific problems and then come up with a plan on how to overcome them. And I was so fortunate that she took an interest in my interest in the evaluation, post implementation evaluation of TeamBirth. And she put me in touch and she got me into all of these virtual meetings across the country, to include Washington, to include Virginia, of hospitals that were in varying stages of implementing TeamBirth. Some of them were in the process of just now implementing TeamBirth. Some of them were 5 years post implementation. And it seemed like they were convening and identifying, much like us, identifying some of these challenges and coming up with plans on how to mitigate some of those problems. So again, we were able to get perspective from a national, regional, and departmental level. All right, we're here. We've made it to conclusion. We have made it to the end. Outside of the reflection, we still need to talk about the reflection after this. But I wanted to summarize and highlight some key takeaways from each of these projects. So for our Safe Sleep campaign, I think that this campaign was extremely effective. I do think that we made a difference in the community, and it was something that a lot of people thought they were just going to be walking into the community health center or the hospital for the day to get their checkup, to get their appointment, and they were able to get a little bit more information about infant safe sleep and take it home and be able to share that information with their community and their family. I think we were able to make an impact on the Boston community in a culturally sensitive way. And I do think that moving forward, there would need to be some improvements in the Spanish work products. But overall, the resources developed and made available to the community, I think, were well received and informative. All right, for TeamBirth, while 3 years might seem like a long time post implementation of a program, this care model is definitely still very fresh and new to the clinical staff, especially the staff that's been there for literally decades. So I do think that like 3 year chunk, the 3 year post implementation evaluation was actually like a perfect time for labor and delivery and antepartum to evaluate how TeamBirth was being executed in the hospital. This project was helpful in highlighting areas that required some revisiting and re-education. And then moving forward, I've left my findings with the labor and delivery and antepartum leadership teams. And I'd advised with my, not quite graduated from my master's in public health program and my no experience in a clinical setting advisement that I think that small group sessions should continue to happen quarterly for at least the next year to ensure that re-education and proper initial education for new hires that are like constantly rolling into the hospital. All right, we're here at the reflection. I'm going to discuss academic, professional, and personal reflections that I had with these projects in this APE. Academically, this AP helped me to display skills that I've learned through my MPH in data interpretation, program evaluation, communication skills and strategies, definitely stakeholder engagement, health education, and personally, what was really important to me in these projects, specifically with Safe Sleep, is cultural humility. Professionally, this APE kind of helped me figure out and get a better grasp on what I want to do in the future. So not only did it help me kind of define a path in which I think I want to take following my MPH, but it also helped with practical experience and what public health looks like practically for day-to-day operations. Um, it also helped me build relationships. So during the course of all of this, I built relationships with OBs, with midwives, with clinical implementation specialists, with community partners, all things, or all perspectives and professions that I had zero contact with prior to this project and this internship, that helped me gain a clinical experience that I never knew that I needed. So with that clinical experience, I think it invigorated, or it at least inspired some interest in wanting to practice public health in a clinical fashion. On top of that, it helped me figure out and learn more about navigating clinical systems, which is something I'd never been exposed to before, and also administrative structures and what the hierarchy is, and who, what, and when to talk to people in order to get more information or more buy-in or a better seat at the table to, just be heard or to listen. Personally, so we'll start with my strengths and weaknesses. How this APE helped me understand my strengths and weaknesses. Frankly, I'm not surprised by what my strengths and my weaknesses were. For my strengths, I would say that adaptability, communication, and initiative were definitely my strengths. I know I am this type A personality where, when given a project or something to get off the ground and get running, I have no problem with initiative. I love seeing how far I can take something and how I can hand it off and see what it becomes. So adaptability and initiative, no problem. My communication, I thought that, like, whether it was in person or virtually via like a Zoom or virtual meeting and emails, communication was no problem. And in fact, I think the communication that I had was able to get me that much further in these projects. For my weaknesses, again, not surprised. I had difficulty in time, not necessarily time management, but being able to define when I was going to be done with something. For instance, when would I stop accruing data or taking the survey, the participation from the surveys? I needed to find a point on which I cut it off. I needed to find a point in which I told the people, because it was an internship and this was short term, I needed to be able to find a time on when I was going to stop doing this program and hand it back over to the hospital administrators it would be more appropriately in their hands. And I think that's being able to identify boundaries in a professional and personal way is something that I've always struggled with and I will continue to work on. As I had mentioned, being in a clinical environment, helped me choose, I think, my future goals. So I will be very happy to take this NPH and hopefully apply it in a clinical setting. I would love to. I'm currently back in school full time, trying to go through nursing school. So hopefully there is a near future in which I am a public health nurse. And then lastly, preparation for employment. How does this AP help me personally for my preparation for employment? ultimately, I'd say it enhanced my confidence. And it enhanced my confidence in a couple of different ways. Enhanced my confidence in being able to collaborate in interdisciplinary collaboration is what I'm trying to say. Um, Having the confidence to be able to know who to talk to, and why to talk to them, and who the best person is. Identifying who the best person is to talk to. Um, and enhance confidence in community engagement. So we live in a world where it's mostly online these days, to include this MPH, to include this presentation. And I'm not gonna lie, sometimes it's hard to just put yourself out there in a physical capacity, walking into people's offices to ask questions, uh, talking face to face about uncomfortable topics like, hey, is this team birth thing really working? Tell me what you think the problems and the challenges are. In a world where it's really easy to have a composed script to do a presentation, or have a camera to hide behind sometimes. I think that this project helped me with my confidence in just being able to get out there and be integrated into the community. All right, and here we are. We are at the end of my presentation, and I'd just like to thank everybody who stayed and listened and participated in my presentation of my applied practice experience with Brigham and Women's Hospital for my Safe Sleep campaign and for a post-implementation evaluation of teen birth. This has been a great experience. I'm so grateful and stunned by the community and the staff members at these hospitals and these community health centers that are so committed to public health in ways that I don't even know if they recognize that they're doing. But I'm so glad to be concluding this APE, but I'm also very grateful for what it has taught me. Thank you.